and I will now introduce our presenters. Dr. Ifeyinwa Osunkwo and Dr. Raymona Lawrence are dual principal investigators for the PCORI-funded Step-Up Transition Study looking at the comparative effectiveness of a structured education-based transition program with or without peer mentoring intervention. And we'll be hearing a lot more about that program in a minute. Dr. Ifey is the medical director of the Sickle Cell Program at the Levine Cancer Institute at Atrium Health in Charlotte, North Carolina. She has over 2 decades of clinical and research experience in sickle cell disease. She's board certified in pediatrics and pediatric hematology oncology and has dedicated her current practice to improving care outcomes for adolescents and adults living with sickle cell disease. Her clinical interests include improving health literacy, adolescent transition, chronic pain, and bone health in sickle cell disease. She's one of 3 principal investigators of the multi-state Embrace Network Sickle Cell Treatment Demonstration Project, representing the Southeast region. She's a member of the American Society of Hematology, the Sickle Cell Adult Provider Network, the Global Sickle Cell Network, and is a fellow of the American Academy of Pediatrics. She is editor-in-chief of Journal of Hematology Research and a guest reviewer for several scientific journals. Dr. Raymona Lawrence is an associate professor of community health behavior and education in the Jianping Su College of Public Health at Georgia Southern University. Her main research focus is community engagement in rural, hard-to-reach populations, especially those with sickle cell disease. Her approach to research is primarily qualitative. Dr. Lawrence has been an investigator on numerous rural health and sickle cell disease-related grants. Dr. Lawrence also serves as the Director of Research for the Sickle Cell Community Consortium and as the Editor-in-Chief of the Journal of the Georgia Public Health Association. Wow, to both of you. I will now turn the presentation over to Dr.
Ifey. Hi, everybody. This is Ifeyinwa Osunkwo, and it's a pleasure to be on this webinar. Raymona and I, we just wrapped up our 1-year report to PCORI, so needless to say, this has been an exciting 1 year. Next slide. So a little bit about the history of the study. We heard about the RFA from PCORI, and we put together a team of collaborators and partners to write this project up and submit the grant. And Trevor Thompson, who is a sickle cell advocate who lived in Tennessee and ran the foundation in Tennessee, he also was a PhD researcher in education and was really interested in peer mentoring. He was one of our co-investigators, and he passed away from sickle cell complications while we were writing the grant. And so the community decided that the project would be named after him. The logo, if you can go back 1 slide, Faith, and this ties into the community engagement that Raymona is going to talk about. The logo depicts what life is like for a young person with sickle cell disease. It's purple. As they get into early adolescence, it becomes a little bit more rocky and challenging. That's the yellow book. And then the period between 16 to 25 years of age is pretty difficult and challenging, and we end up losing a lot of patients during this period. That's the red book that is kind of bent on its end. When they do better and begin to get established in adult care, it looks blue. And when they're firmly established and self-sufficient, their life becomes more like the green book that is sturdy. And so we want to move the time between the purple book and the green book to a much shorter period of time and a lot less rocky. So the logo depicts what we're trying to get to. The stick figures on top, you have the mentee, which is a young adult with sickle cell disease. You have the mentor in the middle, and you have an advisor at the top. And just keep that in mind as we go through the presentation. Next slide. Next slide. So this is the 2 PIs on this project. Next slide. It's always important to mention that it takes a lot of people to run a project. You're not going to be tested on this table, but these are the members of the GCC at Atrium Health and our external collaborators and co-investigators. Next slide. And to give you a perspective on the scope of this project, there are 14 sites. Each site has a pediatric PI, an adult PI, and a CBO partner. So imagine the sub-awards that had to be executed to implement this study. It was 14 sites with 3 contracts each, plus our numerous consultants and collaborators. So it's a pretty hefty undertaking. Next slide. And so the reason why we decided to do this project was because we all identified the fact that a child in pediatrics is sitting in a warm tub of water with bubble bath and the rubber ducky, and life is pretty cool in pediatric sickle cell disease, where you have all the support and all the nurturing and caregiving. However, you turn 18 and you get thrust out into the dark unknown, and it feels like you're throwing the baby out with the bathwater. And the goal is to have it planned rather than unplanned. Next slide.
Hold on a sec.
Okay. So at the end of the day, everybody will transition. A child is going to grow up and become a young person and become an adult. And if you have a chronic healthcare condition, you're going to have to go from using children's services to this in-between zone and then fully embed yourself in adult services. It's not bad or good, it's just different. And if you think about the fishbowl where you have a goldfish, you're leaving one fishbowl that has a certain temperature and a certain pH acidity to another fishbowl that is really just a different environment. And you adapt to that environment if you plan and you prepare yourself for that change. Next slide. So what do we want to get to? We want to get to a situation where all of our young adults are like this picture. They graduate from high school, go on to college, they have life successes. However, it's not just graduating on the outside. We want them to also graduate on the inside, where they, click on the next slide, they end up on the adult environment with not just a hard exterior that is self-sufficient, but also a competent and strong interior. So they have the Superman strength on the inside that helps them get through the rocks and the tumbles of life. Next slide. So what is transition and why step up? The American Academy of Pediatrics, the Family Medicine and Internal Medicine banded together in the 2000s and came up with a definition and a template of what this should look like in the healthcare system. And the words that are highlighted in purple kind of emphasize the critical pieces. So it needs to be dynamic, and it's a lifelong process. You're going to grow up from being a baby to a kindergartner to middle school to high school to college, pediatrics to adult care. Then you go into middle age and then geriatrics. Premenstrual to menstrual to menopausal. So it's a dynamic lifelong process. And you need to make sure that we are meeting the individual needs of the patient, and that we're maximizing their lifelong functioning and potential, and that the care we provide is not just high quality, but is appropriate to their level of development and the developmental stage. But also, which is something we don't particularly pay attention to, it needs to be uninterrupted as they move from stage to stage to stage. Next slide. So part of the goal of optimal transition is to reduce these negative risk factors that compromise the outcomes of our young adults with sickle cell disease. We want to reduce the 3 times higher mortality of our young adults. We want to reduce the enormous acute care utilization and readmission rates in these young adults with sickle cell disease. We also want to improve the absenteeism rate and also their scores on standardized testing. We want them to be able to achieve better job and financial security and improve the overall quality of life and the quantity of their life. Next slide. But there's so many barriers. There's barriers on the patient level, the parent level, the pediatric provider level, the adult provider level, and the system and the community. And we want to avoid this scenario where nobody is talking to each other in a language that they each understand. And there's a lot of gaps of continuity between the pediatric program, the adult program, the patient and the parent, and then the messaging from the community and the society. This picture shows you that you have a young adult who's going to adult care who really doesn't trust the adult provider. The adult provider doesn't know what they were told, so he can't keep the story straight. The parent doesn't trust him because she thinks this is going to be very different. I don't know if you know what's going on. And this can really be solved by making the communication a little bit more robust, where everybody is talking to each other and speaking the same language. Next slide. So next slide. What are the problems that we see with transition? And I put this upside down on purpose. So the health system is not structured in a way that is easy for a chronically ill person to navigate. If you've ever tried to make an appointment for with a doctor, at least myself, you have to make a phone call, be put on hold. They give you 5 different options, and with my short attention span, by the time I get to option 5, I forget what option 1 said. And so you end up spending so much time trying to make this appointment. And imagine a person who has a chronically ill child. The young adult has chronic pain or acute pain, is on medication. They can't do this on their own. And if you have many doctors to navigate through the system, it's even more difficult. On the patient side, a young adult is different from a child, but also very, very different from an adult. They have to go through that process of becoming more independent, but they also have a hard time navigating becoming an adult in terms of responsibility, remembering what they're supposed to do, keeping track of stuff. They don't want help, but then they want help, and they think they know everything, but they really don't. And then in pediatrics, we tend to be almost over maternalistic. We want to solve all of your problems and fix everything for you, and we almost like paralyze you from doing things on your own. Whereas on the adult side, they are very, very independent, and they push the patients to be very independent, which may or may not be the right thing to do for a young adult who really has never exercised that degree of independence. And on the community level, even though sickle cell is an under-resourced condition, when there are resources, sometimes we're not talking to each other. So the community is doing one thing, and the medical folk are doing something else, and there's a lot of overlap and repetition that could easily be avoided if we banded together and, again, spoke the same language. Next slide. So how do we get to a perfect utopia? Well, we got to remember that every individual is made up of a body, the psychology part, and then the social part. And if you only address the transition in one area, you're never going to get to that point where they are successful. So the biology of their disease is important, but it's not just the biology of the disease, because if they're depressed, anxious, stressed, or have identity issues, they will not buy into their treatment regimen that helps their disease get better. If they have significant isolation, poor finances, lack of stability in their social life, then they cannot engage in adequate health care to keep them out of the hospital. So again, you want to look at this from a biopsychosocial model of chronic disease management and address all aspects of the individual's life. Next. So in this project, we really use this model of developmental, biopsychosocial, ecological transition to emphasize the fact that you intervene in the patient level, but also on the society level and then the healthcare system level. And individuals with sickle cell disease need to kind of grow from a place where they're young and where the mom or dad is doing everything to where they're older and they have connectivity with their support, but they take more autonomy in doing things for themselves and navigating the system of their healthcare by themselves. Next slide. So where are we trying to get to? We want to get a child who is living with sickle cell disease with an engaged and active family and move them to where they're an adult. They still have familial and peer connectivity with social connections, but they're a little bit more independent and what we term in our project interdependent with their resources. But we also want to work on the health system level, the interpersonal level, and in all of this, engage the community as a vital and critical partner to everything that we're trying to do. We want them to learn to become more independent in how they assume responsibility for managing their chronic health care needs. Next slide. Next. Okay, so we decided to look at transition from the perspective of what the patients actually need. They need additional support that is individualized to help them through this process. We realized when we did our literature search that there was no standard on how to do this for sickle cell disease, and quite frankly, no standard for any condition. The literature suggests that if you target and structure your plan for transition, you will do well. We know that there's a gap in education and skill building in young adults with chronic disease, especially with sickle cell disease, and that these young people need to practice these skills over time. We also wanted to do something that was very pragmatic. We don't want to do a study that when we finish the study, the results just sit in a shelf and doesn't impact everybody. So the idea that everybody would benefit from this intervention, whether you get the comparator or the baseline intervention, was our goal, and that it should be available to everybody who has sickle cell disease who comes to clinical practice. We also wanted to be sustainable and also reproducible. Next slide. So our primary objective is to compare the effectiveness of a structured education-based program for transition with or without peer mentoring. And we're looking at reducing the number of acute care visits per year over 24 months. Our primary outcome measure was quantitative because in the literature, there was really nothing qualitative or PRO related that could be used as a way of doing our power calculation. But we did add secondary outcomes that were patient reported. So the ASME quality of care, the PUTS-QL, looking at social support, measuring their readiness to transition, and then feedback in terms of satisfaction from the patient and also the provider perspective. Next slide. So our schema, we divided our sites into two. So some of them are large, some of them are small. This is a very diverse population that spans the Southeast USA. And we have a site in Virginia and also in New York City. But we know that programs are different based on whether they're academic or non-academic, urban, rural, urban and rural, et cetera. And so to balance the site in terms of reducing variability, we looked at sites as large or small based on a number of young adults who are in pediatrics between the ages of 16 and 25, and they're going to be randomized by site to either getting peer mentoring or not getting peer mentoring. Next slide. This is a prospective double-arm, unblinded, cluster randomized study. It's very difficult to blind a study like this. We clustered by site based on the fact that patients talk to each other in the waiting room and on social media, and they meet at the mall if they go to the same provider. And so we wanted to reduce the level of contamination across the study sites. We're looking at 14 sites, and we plan to enroll 700 patients, with 7 sites getting peer mentoring and 7 getting the standardized intervention. Again, we're going to recruit over 24 months, and we're going to monitor them for 24 months on study. Next slide. So what is the standard arm? The standard arm we kind of banded together and discussed not just among the investigators, but patient stakeholders, community-based organizations. We all agreed that everybody should get something. And so we want to help every clinic standardize how they do transition in their clinical practice on the pediatric side and on the adult side. And we're using the model for improvement, quality improvement methodology to implement the change package that will put in place the 6 core elements of transition that has been popularized by gottransition.org on how to handle every young adult patient visit from the ages of 12 all the way up to when they leave pediatrics, and then even when they get into adult care until they're in there for at least 2 years. And the goal is to track the process and outcome of this intervention so that every patient, every time, every visit benefits. We also made sure that we embedded the community-based organization as part of the research team. So this is a collaboration between the community-based organization, the providers, the clinic staff, and the patients to improve the system of care for young adults or emerging adults with sickle cell disease. Next slide. Next slide. And so the targeted education, if you can go back one, please. Go back, okay. So the targeted education is really using a standardized education module to address gaps that you find out in the readiness of assessment for transition using a standardized assessment. Using the TIP, which is a tool that was designed by Wallace Smith and folks in California to look at sickle cell disease specific readiness for transition. And then based on those gaps, you provide education that addresses those knowledge gaps and skills, and then you repeatedly reinforce this as it comes to clinic so that it sticks. And then you do this on the pediatric side and also on the adult side. Next slide. This is a snapshot of the peer mentoring platform. When we began this project, we thought it was going to be one-on-one personal intervention in terms of the mentoring intervention. However, that is not a reproducible intervention or sustainable. And so there is the opportunity to kind of leverage what's been done in other chronic diseases where you mentor telephonically or by text messaging, but it's all virtual. And then you can use the same template to mentor several different people at several different times and locations. And so we're going to engage mentors and advisors to mentor young adults telephonically to help them with behavioral changes that will support transition readiness and success. They'll be trained using the virtual platform, and they will have supplemental in-person training at the community-based organization. Everything is virtual. There's going to be no face-to-face interaction between mentor and mentee. The platform is HIPAA compliant, and we structure our protocol based on a level of volume that we believe a mentor can handle. So a mentor should not have any more than 3 mentees, and we also have every mentor paired to an advisor who can also support them in terms of helping them with dealing with having sickle cell disease as an adult. And this came about after we lost Trevor, who was a great mentor for several people, but when he died, many of the older sickle cell individuals felt like, you know what, we need support too, because we have to face the fear and the anxiety about dealing with our mentee who may not be doing well, but also our friends and also ourselves. Next slide. So they came up with this, the concept of the village mentoring, where the advisor has 5 mentors, and each mentor is matched with no more than 3 mentees. Again, everybody benefits, so the mentors benefit from giving back, and they benefit from the help of an advisor. The advisors benefit because they feel like they're giving back and they wish they had that opportunity, and they also provide input to the study team to help move things forward and improve the project. Next slide. So our comparator, as I mentioned, is peer mentoring. They're going to be consented in clinic. The training of the mentor takes about 8 to 10 hours virtually, and then they're going to have additional training at the CBO once they've started their mentoring process. All interaction is by platform and virtually only, and they're required to make weekly calls for the first 3 months, and then every 2 weeks thereafter. And for the advisors, they call once a month. Next slide. Inclusion criteria for the young adults with sickle cell disease, they have to be between 16 and 25. In pediatrics, we want them to be able to stay in pediatrics for at least 6 months before they move to adult care, so they can benefit from the intervention on the pediatric side and on the adult side. They cannot be pregnant, and they have to sign the appropriate HIPAA and informed consent authorizations. Next slide. To be a mentor or an advisor, you have to be 26 to be a mentor or 36 to be an advisor, be able to have a computer with internet access that you have available to you to do the mentoring. You have to pass a background check, read and understand English, and be legally able to work in the United States. You also have to have an attestation by your doctor that you've had continuous care of about a year, and that they feel that you will be a good mentor. So we have a provider endorsement requirement as well for the mentors and the advisors. Next slide. So for those who are not familiar with the quality improvement component of research, next slide. Part of what's going to be given to the site, so every site will benefit from learning and becoming proficient at implementing quality improvements into their practice. We help them generate specific changes to improve the process of transition in their clinic on the adult side and on the pediatric side. We've begun to work on having the policy established in the clinic, which is element 1. Element 2 is develop a process for tracking and monitoring your young adults. Element 3 is formalizing the process of preparing the young adult and orienting them to adult practice. Element 4 is planning and integration into your practice, and element 5 is a transfer with the initial adult care visit, and element 6 is complete transfer of care or ongoing care where they're established in the adult practice. And this is modified based on whether you're in pediatrics or whether you're on the adult side. And basically we have monthly calls with a quality improvement coach. They work on small tests of changes in PDSA cycles, and we have a lot of health literacy education that we've put in place to help people understand that when you're doing things in the clinic, it needs to be in a way that the patients can understand and really comprehend, and that they feel is beneficial to them. And they are required to have a patient advisor on their QI team to help guide them to make sure that whatever they're doing in terms of changes are patient-centric and also developmentally appropriate for the population. Next slide. The next several slides give you some of the tools that we're using for our quality improvement process. So this is a process measurement tool that looks at what is happening on the pediatric clinic, and then the next slide shows what's happening on the adult clinic. And we score them, we have them self-score themselves, and then we validate that score with supportive documentation. I'll give you an example is element 1. Do you have in your clinic a written policy statement that describes a process or approach to transition with input from your young adults? Well, if you have a policy but nobody gave you input from the patient population, you will score a 0. Once you get input and you revise your policy accordingly, then you score a 5. And everybody starts low, and with the goal that we're going to improve our score over time. Next slide. So we use the PDSA cycle where you plan, you do, you study, and you act. And I'll give you examples as we go along. So if you click on the next slide. So you have an aim. For example, we want to have the policy given to every patient in our clinic so that every young adult from age 12 knows that they're going to transition, they're going to leave and go to adult care by age X, and that when they go to adult care, this is what's going to happen, and that when they turn 16, they are going to have a visit with their doctor by themselves, et cetera, and so forth. Well, so how do you do this? You now have a plan of what you want to do, which is give the policy to every patient by January 31st. Next slide. As a team, you have to decide what process do you use to make this plan possible. How are you going to start? What are you going to do? Next slide. Then you all agree we're going to give the policy to people in clinic when they are leaving the clinic. So there's something called the D part, where when you see a doctor and you're leaving, they give you instructions on how to, manage your care when you leave until the next appointment. It's called the D part instructions. We're required to do this based on medical documentation rules, so everybody should get this. So we put this in place. Next slide. Then we study it. Well, the last 3 patients that were seen did not get their D part. So then you want to find out, why did that happen? Well, one person was sick and had to go to the ER. One person, the mom was in a hurry. The other person left it in the room and didn't take it with them. You find out what those reasons are. Well, then this is not a good process. So how do you change your process? So the next step is, next slide, you modify your plan. So how about we give the policy when they check in? So when they check in, there's usually a time of introspection and waiting that happens at the doctor's office, and that may be a beautiful time to share the policy with the patient and their family before they actually see the doctor, and it actually triggers some questions during the visit. So these small changes are happening at every clinic that is part of this study. Next slide. I'm just going to run through these tools that we have. This is our assessment tool to determine how ready a young adult is. It's called the TIP RFT. Next slide. The goal is to have this done every 6 months on the study, and if you find any gaps, you begin to address them. So it kind of focuses your visit, so you make sure that they have what they need before they leave your part of care, and also when they get into adult care, you do the same thing and review what they've gained and help reinforce it. Next slide. You will be amazed at how unstandardized medical information transfer from provider to provider is. The American Society of Hematology has a transfer summary that they made for sickle cell disease. It's very crisp, it's very succinct, and if you give this to any doctor, they have everything they need to know to take care of you. But none of us do it. And so we want to help providers in their practices put this in place where your medical summary is 3 pages, not 3 shoeboxes full of medical documents that you send to the doctor, and it gets to us when the patient has been with us for about a year. Next slide. What I like about this summary is that the additional information box allows you to put in some very specific, nuanced information that may help us take care of the patient better. For example, he doesn't like alcohol prep. He rather has betadine when he has his IV done, or use a 24-gauge needle, not a 22-gauge needle, etc. Next slide. This is a sample of an emergency care plan. The new sickle cell guidelines recommend that we have a care plan for each patient that is individualized, that they can take with them when they go to see another doctor or they go to the emergency room. And the goal is to have a template that people can use to put this in place in their clinical practice. So this is our template. They can modify it and adjust it accordingly. This was designed by our sickle cell program here in Charlotte, but we got input from the Sickle Cell Consortium, sickle cell patients, and some of the community-based organizations when we were developing this action plan. So again, you want this to be patient-centered when you roll it out. Next slide. This is the ER version, and the other one was a patient version. Next slide. I'm going to skip over this. This really talks about the details of what you do when you come to clinic to see the doctor. Next slide. Next slide. So where are we with this study? We've enrolled, our first patient was enrolled on January 18th. We have 5 patients enrolled right now. Part of our goal is to make sure that this is a study that completes its enrollment on target. So again, spread the word. Next slide. We are hoping to make sure that we, again, do not have any zeros or reds on our enrollment log. But part of the beauty of this study is that we have a very, very robust engagement plan that Raymona is going to talk about next, that really is going to help bridge this gap between the patient and research in the way that we've always thought about research. So I'm going to pass it on to Raymona.
Next slide, please. So a little bit about the engagement plan. What we do in the study, you can go to the next slide, thank you. So our approach to the study is a community-based participatory research approach. And so as Ify was just saying, our engagement approach is extremely robust. It is what we do and what we've done as we work together over the past several years, but also an integral part of what you have to do when you have a PCORI-funded study. And so with community-based participatory research, it enhances collaborative efforts among community members, academics, clinicians, and other stakeholders who use research to build on the strengths and priorities of the community for multi-level strategies to improve health and social equity. And so what we're doing is bridging that gap between all of the different entities and stakeholders that we have, and making sure that this process is driven by the community and not by us just as researchers. Okay, next slide. So when we were thinking about this study and how we would develop it and how we would go about engagement, we thought, well, it's important for us to have an engagement purpose statement. We always think about the word engagement and we say the word, but what does it really mean? And so we wanted to make sure that all partners were on the same page, because often what happens is we say we're doing engagement and everybody has a different idea of what that is. And so at the end, we come up with different outcomes. And that's not what we wanted for this particular study. And so our statement was developed by the individuals in the study. All of the stakeholders had a part in developing this purpose statement. We had individuals with sickle cell disease who initially developed the first draft of this, and then we took it to our step-up study meeting so that they could further tweak it, and we went about a process of editing this until all of the stakeholders were pleased. And so our statement is to ensure that we collaboratively, and that is a big part of this statement, is to make sure that what we call our site triads work together. So we want to collaboratively empower, motivate, and contribute to the quality of life of emerging adults with sickle cell disease to create a foundation for successful transition. This study will provide them with the comprehensive tools to be effective advocates, leaders, and champions, and this is key for their individual well-being, because we know that sickle cell disease is a issue that they have to deal with as far as their own individual health, but also with community engagement, because we want them to grow into adults who are successful citizens in society and not just successful with their clinical care. And so as we think about our foundation of the biopsychosocial ecological model, we not only want to focus on their individual well-being, but also up through the model and look at community engagement and their context that they're in, okay? So this is our engagement, next slide, yes. So this is our engagement diagram. And so as you can see, everything that we do is, the engagement is the umbrella for it. And so even overshadowing PCORI is engagement. It's our thought process. It's what we think of in every aspect of the study. It's not just a separate piece of the study, but a part of everything. And so we have, of course, PCORI, and we as principal investigators, Ify and I, talk to PCORI. We are in direct contact with them, and then we have the individuals at the Data Coordinating Center, the DCC, and the DCC talks with all of the other entities of the study. So there are, as you can imagine, a lot of moving parts within the study. And so we have the scientific oversight group, which of course looks at the science and makes sure that everything is in line with protocol. That group is the Data Safety Monitoring Board is constituted by that group. We also have the Step Up Study Team. So the Step Up Study Team is all of the individuals on the study. So the adult PIs, the pediatric PIs, we have our patients, we have our consultants, the individuals at the DCC, the CBOs, everybody is on the Step Up Study Team. But then we have a separate Study Advisory Council. So within the Study Advisory Council, that is a group that meets separately from the Step Up Study Team, and they are representatives of what we call in the study colleague categories. So everyone has a colleague category. So for instance, a CBO is a colleague category. So there's a CBO representative that speaks with all of the other CBOs and gathers information. An adult PI would talk with other adult PIs. And so they gather the information from the individuals within the study, and they represent them. And so they're not on the Study Advisory Council to give their own opinions. We have them to go and get the information from their colleagues, and then they bring it back to us, and we use that information to tweak different pieces of the study. And so typically they do this by email, and so we'll have set questions that the SAC comes up with. They email the information out, get the responses, and we come back and edit specific parts of the study. So one report that has recently gone out was to collect facilitators and barriers of engagement within the study. And so asking them about how the triad works together, recruitment, and different things like that. And so we use that information as a way of engaging everyone to make sure that they all have input into how the study is implemented. So the SAC, those individuals rotate out, and so they have a year-long tenure, and we rotate others in, as they are moving out. So there's continuity across that group. We also have the quality improvement team, and all of the sites, regardless of the arm, participate in the QI process. And of course, we have the peer mentoring versus the standard transition programming, and each one of the sites has a community advisory board, regardless of arm. And so then the DCC, again, communicates with every aspect of the study, and all of the data communication flows back to the data coordinating center. And so that is just a snapshot of how we do engagement within the study. Okay, next slide. So our engagement goals, the first goal was to establish this Study Advisory Council. It would be comprised of key patients, providers, community stakeholders, and they provide the insight and guidance on the project protocol development, as I just mentioned in the last slide. And so they meet monthly, and again, they gather the information, and we use it immediately to start to implement change within the study. We also have engagement goal 2. Now, this goal was not something that we came up with initially. When we had the study kickoff meeting, we learned that there was some issue with bonding within the site triad. So the site triad, again, is the pediatric and adult providers or the clinicians, the community-based organizations, and the patients. So we realized that the CBOs were feeling a little bit left out, and that none of the entities understood everyone else's value. And so we realized that if we could get them to effectively communicate, then by the end of the study, then we would really have done something great, especially for sickle cell disease. And so this is where engagement goal 2 came from. At the study site meeting, it is one of the results of that. And so we want to establish effective, sustainable partnerships and communication within the study site triad. And so these partnerships, they help us to meet our recruitment goals and ensure that the sites move along with implementing a standard transition process. Okay, next slide. So engagement strategy. So in this particular study, we always have fun with engagement. We really really take the engagement theme to the extreme. And we want to make sure that all partners have a lot of fun doing this. And so they think about engagement in a typical, marriage type of way. And so we pulled some marriage quotes to give you some indication of some engagement strategies and how they work. And so a 3-strand cord is not easily broken, right? So we have the site triad in our study. And so, again, the adult and pediatric providers, the community-based organization, as well as the patient. And so when we have that strength in that triad, then it is not easily broken. And that is something that we really need in sickle cell disease to ensure that we reach the outcomes that we want. The next quote is, coming together is a beginning, keeping together is progress, and working together is really success. And so one of our strategies is to build strong triads, to develop them strong, and then to have them strong throughout the implementation process. And so we have made sure that the triads work together. We have had them to do icebreakers, sit together, think through things, develop goals, SMART goals, strategies that would help them to truly work together and to really have a paradigm shift. Because what has been happening is that they think of each other separately. The CBOs do some things, the providers do some things, but they don't think of each other as the solution to the problem. So if a provider is thinking of how do I fill this gap, then they've got to start thinking of the CBOs as a way to possibly do that. And so that is something that we're really working on in this study. Also, the community engaged study is one place where a doctor ought to forget that he's a doctor. The community engaged study is the one place where a PhD ought to forget that he's a PhD, and it's one place that the school teacher ought to forget the degree she has behind her name. And for that, we have really tried to eliminate titles. We take off the MDs, the PhDs, all of other letters that someone may have behind their name, and make sure that everybody knows that they are just as important a part of the process as everyone else. And so we've given them a title. We give everyone the title, Engaged Sickle Cell Advocate, and that's what you are. So as you saw on our pictures in the very beginning of me and Ify, we don't have our titles on there. It just says Engaged Sickle Cell Advocate, and that's where that came from, is because we're not the big PIs and they're the little people that, we all work together, and everybody's opinion is valued and very much needed to reach those outcomes. Also, health is the first wealth, and the second one is the happy marriage. And so, again, we do things at the meeting. We have them to take fun pictures that we're about to show you. They have engagement dinners. They got marriage certificates within their site triad. And so we throw candy at them. I mean, all kinds of things to keep them awake and engaged in the process of really working together and developing that triad. And so we really, really try to make everything fun. Okay, next slide. So here are some of the photos. As you can see, this is the DCC, and you see Ify and I in the top left-hand corner there. These are the engagement photos that we started to do. So I'll let you flip to the next slide. So here are some of our consultants, and they all got to dress up as well, and they thought we were crazy, but they enjoyed it and laughed and had a good time, and so they ended up going with it. Next slide. So this is an example of the certificate that they got, and these are some of the site triads and the members of those triads with their CBOs, adult and physicians, and pediatric and transition coordinators together. Okay, next slide. Again, same thing. Keep going. That's fine. Thank you. Go ahead and flip through. And this is the engagement dinner that we had. We had a fun cake and with the logo on it and things for them to eat and to be able to socialize and have fun after a long day of, work and training and different things that they had to do to really think hard about the processes that they have in their sites. Okay. And these are some of the consultants. We had a lot of different consultants that come to talk about health literacy, what happens when you're moving from pediatric to adult care within the clinic setting. And so that is some of those pictures. Next slide. And we also had a patient panel discussion, and this is always really a highlight of the meeting that we have. We do it every time, and we have patients, their caregivers, adult patients, ones who have just transitioned, older patients. And as you can see, we had two physicians moderating the panel this time, and that is, again, another way to facilitate communication within or between patients and physicians, and ensuring that we're bridging that gap so that they learn how to communicate in our meetings, but also translate that to their own sites. Next slide. We also had quality improvement breakout sessions where they learned to, they looked at their QI goals and the things that they have already established for QI with our QI directors and different sessions that they needed to go through to make sure that they are aligning their goals with what they're even doing for engagement. Okay. Next slide. So a few other lessons learned. Before you marry a person, you should first make them use a computer with slow internet to see who they really are. And this lesson is to adjust to communities and partners' pace and with a smile, because this process is very slow going sometimes. Communities are at different levels of capacity. They are at different levels of understanding technology, different levels of even reading their email. And so we have definitely learned to to meet them where they are and to enjoy the journey of working with the communities and have them, to leave them with something, teach them something new, let them teach us something. And so doing it with a smile and patience. Okay. So the goal in marriage is not to think alike, but to think together. And so we have tried to help our partners recognize the partnership as the solution to any issues they may face. And so I talked about that a little bit before, is that oftentimes they don't see each other as the solution. They don't think in triads. They think in their own silos. And so we're changing their paradigms that they have and making sure that now they start to think of each other as a possible solution to the situations that come up on site. Okay? And I got gaps, you got gaps, and we fill each other's gaps, right? And so every partner is valued when you're working to fill complex issues related to transition and sickle cell disease. And so we're still working on this, making sure that the physicians understand the value of the CBOs, making sure that everyone understands the value and the intelligence of the patient, and not that they should be just told what to do, that they're a partner in their clinical care. And also that the CBOs and the patients recognize the value of the physicians. And so everybody has a place and everybody has value, and we fill each other's gaps. Okay? And my wife tells me that if I ever decide to leave, she is coming with me. And so we constantly remind our partners why we are engaged, and that we have a common purpose, and that we're all sticking in this together. And so one can't work without the other. One can't move and go and do something else and not have the other one with them. And so we all have to work together to reach the goals of this study. And so those are some of the lessons that we've learned and that we try to impart in our partners. Okay, next slide. So we just have fun with this, right? Before we say I do, we have to teach them that it is really important to ensure that we're all on the same page, that we have fun being engaged, and that we truly, truly enjoy the journey of this process. Okay, next slide. So this is a Chinese proverb that we really live by, and it's tell me and I forget. Show me, I remember. Involve me, I understand. And engage me, and I own it. And this is what is going to cause sustainability, and also not only in the sickle cell community, but how do we move this beyond the study to other patient groups and beyond the groups that are just within this study to really make permanent change with transition from pediatric to adult care in sickle cell disease. Next slide. So why are we here? Why are we doing this study? We want to change systems and support the emerging adult with sickle cell disease to be successful well into adulthood. What are we doing? We're using quality improvement methods to implement the 6 core elements of transition into pediatric and adult clinics. We'll also provide targeted and individualized education and support to the individual with sickle cell disease during that transition process. How will we do this? We work together, we are engaged, we're open to doing things differently, okay? So thank you all. If you all have any questions, comments, or anything like that, Ify and I are here and open. I don't know if I need to turn it back to Faith first, or if we go and open it.
I'm still here. So I see that some comments came in already, but if you have more questions, please write them in the question box, and then I will read them to our presenters. One question that is already here is, how do others become part of this program? We're in Las Vegas, Nevada, and would be interested. That's
a great question. This is if. So one of the things we would be interested in doing is recruiting mentors. And Shirley Miller, who is one of our patient stakeholders, is going to be meeting with the Sickle Cell Community Consortium in a couple of weeks to kind of share with them how this is going to work. So if you're an interested mentor, then your provider, who is a sickle cell provider, will need to refer you to one of the closest study sites. And just to kind of keep it simple, maybe what I will do is, Faith, I will send you the email to the project manager, and then people can email her to express their interest, and then she can kind of talk to them one-on-one. Okay, I'm going to send that to you.
So I will include that email in the follow-up email that I always send both to the attendees and also to the others who registered but then couldn't make it.
And then the other thing is that we are looking for collaborators, because this is happening in the Southeast, but it should be happening around the country. And there's another study that you'll hear from next month, I believe, on transition, but there's a whole body of the US where nothing is happening. And I think the quality improvement piece can be transferable to any location. So if a sickle cell program wants to do that and join our quality improvement collaborative, we are open and willing and able to kind of have them join and kind of share the same learning. We really are interested in this model of a learning healthcare network where everybody learns from each other. There won't be any funding associated with that, but if you want to learn the tools and the techniques, we can share those with any clinic that's interested in being a part of that.
Perfect. So were you referring to the other PCORI project?
Yes.
Okay, so they actually held a webinar at the end of, So they went before you. They went at the end of last year. So we do have the recording and the slides from that project up on the website, and we will send you the link. Let's see. Okay, I can see that you sent the email address, and I'm just gonna, it only went to the organizers, so I'm just gonna copy it and send it to everybody. Let's see. Okay. So there were some comments that came in. One comment was that older sickle cell disease patients need support also. Some comments that the program is very impressive. There was a question about where the study sites are. I believe at the beginning you had a list.
So I can just touch on that briefly. It's in New York, it's Montefiore Medical Center. In Virginia, it's Virginia Commonwealth University. In North Carolina, it's Atrium Health in Charlotte, Novant Health in Charlotte, East Carolina University, Wake Forest University, and Duke University. In South Carolina, it's Greenville Health Systems. In Alabama, it's University of South Alabama in Mobile, University of Alabama in Birmingham. In Florida, it's University of Miami and Johns Hopkins All Children's in St. Petersburg, Florida. And then in Atlanta, it's Emory University and Children's Healthcare of Atlanta. And then University of Louisville, Kentucky. I can't even keep all the numbers straight.
Perfect. Let's see.
Hi, this is Susan. Can I jump in with a question while you're reviewing?
Sure, go ahead.
Thanks. That was just amazing. I'm just astonished at the approach that you've taken, the size of this project, and I think the magnitude of what comes out of this. It's just enormous and really, really exciting to hear about. I was wondering if you could so the focus on engagement of providers, of your mentors, of all the different people who are working on this, in addition to the young people who are transitioning, I think is novel. And I wondered if you could sort of place for us in context what it is about that approach that makes sense in sickle cell disease, or maybe this is something that we do see in other chronic illnesses where young people are transitioning. I have not heard of it before, but if you could just sort of focus on the particular issues around transition and sickle cell disease and why this approach.
Raymona, you want to take that?
Sure. So do you mean, so which part of the approach are you referring to?
And that was a really big question. I'm sorry. I was just sort of.
I just want to make sure I'm answering your question.
I didn't want to give you all of my notes. So I think I've been thinking a lot lately about, in particular with transition, about how how if you're outside the sickle cell world, you look at you say transition is a big problem for any child with a chronic disease moving into adult health care. And thinking about how sickle cell disease is different than any chronic disease, any severe chronic disease. And then as I was listening to your presentation and overlaying your process of really trying to engage lots of people other than the adolescents themselves, which is more typically the focus, I just wondered how you came up with that and how that's different than something like type 1 diabetes or cystic fibrosis or severe asthma.
So when we're thinking about sickle cell disease, you have to realize, one, sickle cell disease is a rare disease, and it's also a huge health disparity, right? And so as we think about how we comprehensively address this, we have to make sure that we're looking across the individual, because when they're transitioning, they're not just transitioning their individual health. They've got to transition out into the bigger world, which comes with the health disparities, the inequities, and all of that. And so for us, looking at it as a comprehensive model across the biopsychosocial ecological model, and also looking at their context and all of the other things that will be working on them and against them as they transition, then we realize that we need to look at many other stakeholders, because only about 10% of their time, if that, is spent in the clinic, right? And so we need to make sure that as we transition them, they're failing because we've only concentrated on that one area of their life, and we're not looking at the whole big world that they have to transition into when they have these other things against them, like, for instance, what I was saying, the health disparities, the issues with even finding an adult provider. I mean, when you look at finding a physician that's just a general practitioner or a primary care physician with any other disease, it may be a little bit easier than it is with sickle cell disease, because again, there are now access issues. A lot of times providers don't take Medicaid, and then they also are not comfortable treating sickle cell disease. And so now we have this whole other list of disparate issues that we have to focus on. And so I think that for us, not having this come from just a research perspective, but looking at this bigger community-based participatory research where it's coming from the patient and looking at the issues that they're actually facing, it is better for us to come with a more comprehensive view of engagement than looking at the lower end of the engagement continuum, where we're only just asking them after we've already developed things, and then it never works because they haven't been involved in the process. So that was kind of a roundabout answer. I hope it answers what you were asking.
Yes, thank you very much. It's really helpful, and I think gives perspective and context, which is appreciated.
No problem.
So this is Faith again. I will say that you are getting a lot of love in the questions.
And then to us, that email, we want to see the love.
I will email you everything so that you can see the love. One quick question is, how can we get a copy of that quality improvement measuring tool worksheet?
So what I would recommend is, if you can have them email me, because I think it's not just, so the sheet is great, but you have to be taught how to use the sheet and what supporting documentation needs to be added to validate what the sheet is. So we work with Gut Transition. We have 2 consultants from the guttransition.org, and they helped us customize that tool for sickle cell disease. So definitely have them email us, and then we'll work with them on giving them the entire, the change packet itself, on how to, not just the sheet, but how to work through the whole process on that sheet.
Perfect. And so your email is part of your presentation at the beginning?
Yes, at the beginning. Yes.
So that will be made available to everybody. Another question, let's see. Someone mentors with teens in person at the Children's Hospital. I don't know if this is Orange County or somewhere else, but anyway, it's a teen transition clinic. And does participation in that program conflict with participating in this program? Could this person also participate?
So the patient cannot participate because they're not part of the study. The mentors we recruit will be trained. They're going to be trained on sickle cell disease knowledge, motivational interviewing, shared decision making, and HIPAA. They have to go through that training. You can mentor remotely because we don't want you to meet the patient, because we want to make sure that this is HIPAA compliant and measurable and transferable to other scenarios. So again, have them just email me and we can kind of go through those different questions directly. One of the goals of doing the remote mentoring is sustainability. if you're going to have Medicaid or insurance companies pay for this, you have to make sure that, one, they can track what you're doing and they can measure what you're doing. And so if you think about diabetes and asthma, I get a call from my asthma case manager every 3 months, and they have a checklist they kind of go through with me. And depending on my answer, they walk down a certain path of conversation and they log it on the computer. So that's how they track how well I'm doing with my asthma. And it's covered by my insurance. And so that's what we want to get to for sickle cell disease, where you are provided this tool or this support as part of your everyday comprehensive care. And then, of course,
Perfect.
the requirements.
Just to be clear, the people writing in, one is from Atlanta and is very interested in being a mentor, and somebody else is asking if there's an age requirement in being a mentor.
Yes, you have to be 26 or older to be a mentor, 36 or older to be an advisor. You have to be in care. You have to be seeing a doctor for your sickle cell disease for at least 1 year continuously, and that includes at least 3 visits in that year. And the doctor has to write a letter saying that he, in his or her estimation, you are going to be a good mentor, whatever that, that they think you're going to be able to be reliable, consistent, you're compliant with your care, etc. So it's not just, not just the age, you have to have, because you need to be in good care and consistent care to be able to mentor somebody to be in good care and consistent care. And they will have to go through a background check. Because we're dealing with young people, so under the age of 18, before we can legally pair you with an adult, we have to make sure that that person is not, doesn't have anything on their background check that may get the project into trouble.
Thank you. So again, you're getting a lot more love and the desire to bring this program to the Western states. And I am going to make a last call for questions. I have one more here, but if you want to ask a question, now is your last chance. And the last question I have is, understandably, this project seems to be taking place in large academic centers. Do you anticipate that the lessons learned can be translated to smaller healthcare settings?
That's a great question. And actually, it's not being held in mostly large academic centers. Remember, the first table showed we have large sites and small sites. For example, in Charlotte, Atrium Health is a large site, Novant Health is a small site, and they have, a very small sickle cell population. Greenville Health System is not an academic, not a big academic center. So we picked a disparity of places where some of them are big academic centers, some of them are small. University of South Alabama is a smaller center. And we're gonna look at rural, urban. We're gonna look at academic and non-academic. We're going to look at what type of sickle cell doctor do you have. Is it a pediatric doctor on the pediatric side, on the adult side? Is it an adult doctor? Is it a adult hematologist, internal medicine doctor? We're going to look at all of that when we do our data analysis. So absolutely. And then the other thing I wanted to mention was it would be important to figure out ways to expand the quality improvements around the country. And so if people are interested in working on a collaborative, they can email myself and Raymona. We can kind of figure something out. With what we're doing with HRSA, the Treatment Demonstration Project, we are hoping to expand this as part of that demonstration project to some of the HRSA sites that are not part of the PCORI grant in the Southeast. So we're working on that as a sidebar. But yes.
Perfect.
A question for Mary Houlihan. She presented on the CDC data initiative. And my question is, the data that you presented, do you have it drilled down by payer type and provider and hospital?
Hey, Effie, so we do have it drilled down by payer type. We show the payer mix by age group for hospitalizations and for emergency department visits. Mm-hmm. We don't have it in the data that we're showing. We don't have it drilled down to location or provider. Because we really try to keep this pretty high level information. However, that is information that can potentially be assessed. And so if that's something you're interested in, let's definitely talk and see kind of what your questions are.
And the reason I ask that is when you look at the Access to Care initiative through HRSA, if we know which doctors or which hospitals are seeing the majority of these patients, then we can target our outreach to those providers so that you're not, boiling the entire ocean. Yeah.
Yep. Yeah, and actually the groups that are working on the HRSA project in California and in Georgia have been very engaged with our surveillance program and are using the information exactly for that as part of the HRSA program.
Okay.
And as part of the NHLBI implementation consortium, the information is definitely being shared when requested with groups that are doing that kind of work for sure. And we welcome and encourage those requests.
So this is Faith. A series of other questions have come in, but it's possible that the person who sent them should just speak directly with Dr. Ify. The questions are, how many advisors are at each site? Is there a limit or ceiling on the number of participants? And also, if most of the engagement is via telephone or text, does that mean there's no opportunities for in-person engagement at all?
So I'll answer that. Yes, there's no opportunity for in-person engagement with people who are on the study. And the reason is you want to be able to measure and track and avoid contamination. So we have to standardize what that interaction looks like. It's hard to do it even on the phone and by text. So if you do it in person, some people have a very bubbly personality, some people don't. And so does that mean that X person is not going to be able to get a mentor? And if you live in a rural area and all you have is a phone, then nobody can get to you. So we need to make this as widely applicable as possible. So for this project, if there's no in-person, it's all telephonic. You have to do the phone. You can supplement with text, and it's all through the platform. So there's no personal phone numbers exchanged. You're going to call the platform number to call your mentee, and they will respond to that platform number to call you.
Thank you, everyone, for your participation. Thank you so much for the presenters. Thank you, everyone, for your participation. Thank you so much for the presenters.